How well does B12 lipo shots work? Well, I don't know what lipo shots, so you may have to give me a little more information about that. But B12 shots, they work if you have B12 deficiency. So one of the sort of the biggest misconceptions is that B12 actually results in any meaningful weight loss. There's no evidence to support that, no scientific evidence that B12 injections do anything for weight loss, although they're often marketed by sleazy doctors and people that they don't. They don't lead to any weight loss. So anyone that told you otherwise is trying to take your money. If you have a true B12 deficiency, then it's important to get your B12 repleted. Next question by Gibby. So I'm on Ozempic and I've lost 48 pounds, but I've kind of stalled. Will it pick up again? That's a really good question. So usually, if weight loss stalls after you've been on a medication and you're on, I'm assuming, Gibby, and you may have to give me a follow-up to this, you're on the maximal dose, the maximum targeted dose, which is 1 milligram right now. It's going to be approved for 2.4 milligrams in the coming year, we suspect, but 1 milligram. Usually when you stall after that one, that's usually probably the maximum benefit you'll get from the medicine. Now, if you are able to make some further adjustments to your approach that allow you to sort of re-examine where you may be able to improve, sometimes there's some additional things that you can optimize within your diet, then you can lose more weight. But we often talk about, if you followed any of my evidence, I think we talked about on our last live Q&A, I like to get away from this idea of target weight. A lot of patients come in with a target weight. They're like, I got to get down to 200 pounds. I got to get down to 150, whatever. I like to talk about best weight. Best weight is the weight at which you've made a maximum number of changes to your life that does not impact the quality of your life, meaning you're not doing things that are making your life miserable and sufferable. You're not having to cut out things completely that you enjoy that otherwise provide you, happiness as part of a balanced sort of lifestyle. But you can always potentially make more changes to that if as long as it's not going to be insufferable. So we talk about best weight being the weight at which you've made the maximum number of changes that you can sustain as part of a healthy lifestyle for you. It's hard to say. Maybe you could be on a higher dose if you're not on 1 milligram. I would say that's another option. Curious about semaglutide. Yeah, I mean, that's been getting a lot of press. I've made 2 videos on semaglutide, so if you haven't seen them, check them out on my page. I go into some of the science of it. But with the newest studies, pretty consistently, so there are really 4 studies now that came out with semaglutide at the higher dose, all showing very good safety, the biggest concerns being kind of intestinal distress, so constipation, nausea, vomiting, diarrhea were the most common, but even that, we're only seeing about 10 to 15% of the time for those various indications. Weight loss on average was around 15%, and depending upon which study you looked at, 30 to 40% of participants that took the semaglutide lost greater than 20%. So really you're talking about like levels of weight loss that are on par with bariatric surgery. That's remarkable, guys. We haven't had anything close to that within the realm of weight loss medications. The closest thing we have is Qsymia, and Qsymia, which is a combination of phentermine and topiramate, that yielded weight loss on average around 12%. And when you subtracted the placebo effect, meaning the group that got a sugar pill instead of Qsymia, the weight loss results was only about 9%. So for semaglutide, the placebo subtracted is around 12 to 13%. So that's independent of diet and exercise. That's the additional benefit you're getting. That's what it means. If I ever use the term placebo subtracted, that means that's the true weight loss effect of the drug outside of diet and exercise. So that's the additive benefit that you get on top of diet and exercise. All right, great question. Semaglutide, very exciting, guys. We're all crossing our fingers that it continues to demonstrate great safety over the long term. We've got like five plus years worth of safety data. No big concerns at this time. we're all crossing our fingers that that continues to be safe even beyond that farther. Oh, I just changed the filter somehow. I don't know how I did that. Liquid diet suggestions. Yeah, so we have at Cedars, I have developed a partnership with a vendor that supplies medical weight loss clinics. I really like their products. They don't supply to individuals, but I can tell you the OptiFast program is very well validated in terms of science. So you can get OptiFast through a number of different channels. HMR is also one that's been scientifically validated. So if you want to do sort of a liquid meal replacement strategy, that works. And then honestly, you can make any type of plan, but I would say if you're gonna create a diet plan around a sort of a liquid meal replacement strategy, I would work with a professional who knows what they're doing, because it can be a little precarious if you're not accounting for the nutrients and your unique health considerations. Are any safe with kidney failure? That's a really great question, Anne. It depends on where you are in terms of your kidney stage. But dulaglutide, which is also known as Trulicity, was studied in individuals who had really progressive kidney disease and considered end-stage kidney disease, and who were also diabetic, and was found to not impact kidney function at all. Meaning the medication is primarily not metabolized by the kidney. So that's when drugs we worry about drugs that are metabolized by the kidney if someone has kidney damage, because then the drug can build up in the system and cause side effects, usually because it's the body's not clearing the drug. Trulicity or dulaglutide doesn't have a lot of kidney involvement, so we don't worry about that. It's cleared through other mechanisms. So Trulicity, aka dulaglutide, which is a sister medication in the same class as semaglutide or Ozempic, that has also been shown to be relatively safe with someone who has kidney issues. Saxenda or semaglutide? Right now, so if you compare the results of Saxenda, which is called a medication called, the generic is called liraglutide. It's liraglutide at 3 milligrams. It is branded Saxenda. I'm even getting them mixed up. It's Saxenda, which is it's basically Victoza, but just the weight loss version. The drug company, they get to rebrand it and then they get to charge you even more money for it. It's a total scam, but in any case, that's the pharmaceutical industry. Saxenda compared, we don't have any head-to-head, so I can't say definitively, but if you look at the studies, Saxenda is a little more potent on average than semaglutide at 1 milligram. You have to understand that the groups they tested them in were not comparable. The semaglutide group was a different type of people. They were different people with different health considerations. So it's really hard to compare them head-to-head. I will tell you, for the people that I'm able to get covered, Saxenda, it's worked really well. I just saw a lady in clinic recently, had lost 20% of her body weight. We've been working with her diet and exercise, and she's been on Saxenda, did really well. I've had similar results in other patients on Saxenda. Semaglutide, I've also had really good results even at the lower doses. So not the 2.4 that everyone's talking about, but even at the 1 milligram dose, I've had some people have 15% plus weight loss, which is pretty remarkable. But obviously paired with a good diet and a comprehensive sort of lifestyle behavioral program, which I offer. So I would say it's hard to say. Maybe if you look at the data, maybe it suggests Saxenda, but it's not clear. What med do you recommend? I don't give medication recommendations. I said it's really personalized. There's not one size fits all. If you saw my recent study about sort of phenotype guided, which is just they grouped a bunch of people based into certain categories depending upon the results of their testing across a wide battery of tests. And from prior studies, we know that if you have a certain kind of profile, or phenotype is the medical term, if you have a certain phenotype, then there are certain medications that work better. If you're someone that's more of an emotional stress eater, then Contrave, which is a bupropion naltrexone combination medication for weight loss, that's been found to be helpful. If you are someone who has a slower metabolism than what we would expect for you, given your health and size, phentermine can be helpful because it can boost your metabolism a little bit. People that have something quote unquote called hungry brain, which just means that you have to eat a lot more than the average person for your size to get full. Qsimia was found to be helpful, and for people who have something called hungry gut, which means that they get hungry really quickly after their meal, or they have something that's objectively fast gastric emptying, which is just kind of a nuanced medical term that is of no relevance to you, but is relevant to the medical community. So they were able to pair, once they were able to identify sort of the individual class that patients generally fell in, they were able to pair them with that medicine. And when they did that sort of classified based directed treatment protocol, it worked better than just kind of the generic prescribing practices that we've always been using. And it was pretty remarkable if you compare the weight loss results between both groups, the sort of the standard way of prescribing it versus this very phenotype or class specific way of prescribing. So that in many ways, I imagine that's going to be developed more. The problem with these specialized tests is, you guys may ask, how do I get tested to figure out what type I am? It was done in a very specialized academic setting. These tests aren't that accessible now, and the professor, who is a friend of mine who led the study, they're working on trying to commercialize it, trying to make it accessible to people, and eventually have a blood test. So they're working on developing actually blood tests that will tell you what kind of type you are in terms of your weight. So really fun, exciting stuff in the pipeline. I know that doesn't answer any of your immediate questions, but I would say it depends. It depends on who you are, what medicine you will respond to. Oh, I see what I'm doing now. I'm swiping. That's what it's doing. Thoughts on Orbera and its effectiveness. Let me look up what Orbera is. I don't know what that is off the top of my head. Non-surgical balloon system. Oh, this is one of the gastric balloons. Intragastric. Yeah, I think it used to be more popular historically. The safety and efficacy around minimally invasive surgery is so great now that I think those types of other sort of intraluminal procedures like the balloon, even lap band guys, really is not being utilized by major centers anymore. I know there's some community surgeons that still offer lap band and do some, but the results aren't as good as with things like sleeve. And sleeve is so safe now, guys. It's as safe as getting your appendix removed or your gallbladder taken out. It's actually safer if you look at the 1-year survival and complications. So I think that's really where it's going, is sort of minimally invasive, robotic guided bariatric surgeries. So I think more and more we're going to see sleeves being sort of the standard when patients need bariatric surgery, and then gastric bypass being an option if they want to lose additional weight, if they didn't kind of meet their health goals that they had for themselves. Or for individuals who have really bad reflux, sleeve is not the best option because it can sometimes make reflux worse. So bypass is often preferred in that case. So Orbera, I don't have a lot of, I would say, I don't have a tremendous amount of knowledge about those. I know that they're generally less effective. They're not necessarily any safer than even doing something like sleeves. So I always tell people, if you have an option for surgery, do that. Also, the medications are getting so good now with some of these newer agents that if you don't qualify for bariatric surgery, there are a lot of options that way that are going to be fairly comparable in terms of their effect. Are most medications actually? No, most of them are not injectable. Most of them are pills. The only injectable ones are a class of medications called GLP-1s that are originally developed as diabetes meds. So that's like Saxenda, Ozempic, Trulicity, Bydureon. Those are injectables. But actually semaglutide, which is Ozempic, has an oral pill version. So Novo Nordisk, the pharmaceutical company, they've created a pill version. It's the only one of its kind. They have proprietary technology that's able to make it possible to be delivered through a pill. That is called Rybelsus. You may have heard this. So that's another option of getting a GLP-1 in a pill form. I'm assuming they're going to look at the pill for weight loss too, but that just hasn't happened yet. Yeah, lost 60 pounds. So this is Oil Girl. Lost 60 pounds as soon as she got off the medicine. She gained back a lot of it. Yeah, so I've talked about this ad nauseum, guys, and it's not very well known amongst even other doctors or sort of the broader community. These medications, the way they work is they provide a physiologic treatment. So every single one of your default positions. Your default biology is to resist weight loss, is to maintain your weight and to be sedentary. That's what we inherited in terms of our biology from our ancestors. To counter that, to try and lose weight, to be physically active, is to go against your biology. So you have to understand when you're doing those things, your biology actually resists your present. That's why it almost feels like there's an inertia to do that, or that's like when you try to lose weight, you start to notice you have yo-yoing, or it becomes really hard, it becomes really insufferable. There's actually physiology that is going on that's resisting your weight loss. So when you take medicine that is directed to help you lose weight, when you have surgery, it's actually to help counteract those signals that are resisting your better efforts to lose weight. And so it's providing a real treatment. So if you stop a real treatment, what happens, just like if you were to stop blood pressure medicine, cholesterol medicine, heart disease medicine, diabetes medicine, those diseases take back over. So like, guys, these are we talk about them being long-term treatments, just like for anything else. So I part of my messaging and education is to get people to understand this, and not just everyday people, but also other doctors. Doctors don't even know this. This is very unfortunately, specialized esoteric stuff. It shouldn't be, but it is. And so part of my goal is to get more people aware of these things, that these are long-term treatments. And this is a long-term issue people have to manage, just like everything else, a part of their health. Diabetic people, yeah, they're great. So most common forms of diabetes, type 2, not type 1. Type 1 is an autoimmune condition, but most common forms of type 2 diabetes have to do with weight. They're weight related. And so if you lose weight, inevitably your blood sugar is under better control. And so a lot of times my patients that come see me that have both diabetes as well as weight issues, when I help them focus on getting their weight under control, their diabetes always improves quite dramatically. And that connection is very clear in the literature, and it's being explored even more so. So I think that, yes, I think a weight loss approach for anyone, and if you are one of these rare people who is fairly thin but has type 2 diabetes, there are a few cases of that. Then weight management may not be helpful. But for most people, that there is a connection between carrying a little bit of excess weight and having type 2 diabetes, or having even pre-diabetes. And both of those conditions get better when you lose weight. Semaglutide, not sure, do we need to be diabetic? Right now, it's only FDA approved for diabetes, type 2 diabetes. I will tell you, I get it approved. If you have a savvy doctor, I've gotten it approved for insulin resistance or metabolic syndrome. If you talk to your doctor and you don't technically qualify, or you have pre-diabetes, you might be able to convince your doctor to try and get it approved for something called insulin resistance or pre-diabetes. The insurance company will force you to try metformin first. And if you don't respond to metformin, or if you're already on metformin and you still need additional treatment, then your doctor can try and get that approved. And I've been able to get approved doing that for a number of patients. So while it's required by FDA, it's FDA approved for type 2 diabetes, you can often get insurance to cover it under the guise of metabolic syndrome. They don't typically cover drugs for weight management, which is just, it's beyond me how ridiculous that is, but that is the case. Opinion on diet sodas, does it mess with insulin? Great question. I did a whole video on this, believe it or not. I think people that tell you diet soda is just as bad for your health as regular soda are crazy. Diet soda has been consistently shown to be more beneficial for weight loss and controlling weight. The issue with diet soda is if people use it as an excuse to then sort of overindulge later, that's where you lose those benefits. But if it's a true substitution for a soda, that has natural sugar in it, or added sugar, cane sugar, then it is better. I mean, the data is very clear on that. Consistently, whether it's in children or adults, it's better. So I would say if you're picking between Coke or Coke Zero is going to be better for your health and managing your weight, without a doubt. Now, that doesn't mean that it's as good as water or equivalent to water. No, like water is always going to be the best for your health. But in terms of a better option between the two, I definitely tell people diet soda is much better to help you transition off regular soda. Much better. It's going to be better for your health in general. Does it affect your blood sugar? There have been shown to be variable responses. Some people's blood sugar can go up, even though it's not real. It's not a real carbohydrate, right? It's a artificial sweetener. Some people's blood sugar, and it just depends. Stevia and erythritol, some of these other newer ones that are kind of more plant-based, have less of an effect from the literature I've seen, but it can be. You may have to monitor that just as an FYI, but it's still not going to be the same as you're drinking just normal sugar water, which is what soda is. It'll still be better than that. Good question. So we're getting a little away from the weight loss medicines. That's okay. I try to get to all your questions. Can you take weight loss drug with Adderall? You can. I have patients that are on a stimulant like Adderall or Vyvanse who are also on other weight loss medications. You just probably shouldn't take phentermine, which is also a stimulant. So that was Mama Cat's question. I wouldn't take both. So I would take a different type of medicine if you're already on a stimulant like Adderall for ADHD, I'm assuming. I'm located in Los Angeles. I have a few videos on that. That's where I practice. I see patients in California. Let's see, what else, guys? I take Rybelsus. I feel like I'm gaining weight. Thoughts on Trulicity for weight loss. I struggle with PCOS. Yeah, so I did one video on PCOS medications. The classic has been metformin, although metformin kind of only leads to modest weight loss. More so, what's been tested, I guess more recently, has been the GLP-1s, which Trulicity is. It's a GLP-1. And so there's some good data, and there's some data that actually may synergize with metformin on top of it. So most insurance companies are going to make you try metformin first and then add a GLP-1 anyways. So you're going to have a hard time just going around metformin because of the way pharmaceutical industry works. So I would just say, I think if you are someone who has PCOS, which often co-occurs with insulin resistance, and you are struggling in managing your weight, I think Trulicity is a great option if your insurance will cover it. I think it's a great option. Great question. What else we got? You may need to see a barrier. My 12-year MD never helped. Yeah, unfortunately, a lot of doctors aren't trained. So this is a good little PSA, and I thought about doing a video on this, but most doctors aren't taught how, what is obesity, what is the biology behind managing someone's weight, what are the different constituents. I remember when I was in med school, which wasn't too long because I'm a fairly recent med grad. When I was in medical school, they told us that obesity and people's challenges with their weight were more issues of them just not controlling themselves, that it was like a discipline issue. And this was in the last 5-7 years. And that people needed to just you needed to help them diet harder and work out more. That's what I was told. That's what I was taught in medical school. And that was in the last decade. And which you guys know, you guys have been through this. How long have you guys been trying to manage your weight? I mean, it's not easy. And then I later learned when I got specialized training in this that that's not even remotely the case, that there is a strong genetic component, that there is a strong biological drive to resist any weight loss, and that the environment plays a huge role in sort of manifesting and realizing that genetic potential and that genetic risk. Some people are just going to have a much easier time gaining weight than others. And then subsequently have a hard time losing weight because of their unique biology, and that real treatments aren't just diet and exercise. Real treatments require physiologic treatment, just like you would treat anything else, like high blood pressure. So a lot of doctors don't know this. So you get this sort of the played out crap that's just okay, I don't believe you. I don't believe you're dieting hard enough. I don't believe you're working out enough. You're coming in and you've gained weight or you haven't lost any weight. And so they tell you, I think you need to try harder, Susie, put the fork down, all of those things, which are, obviously forms of weight bias and shaming, and it comes back to their ignorance that the medical community doesn't really understand that for some reason there's been this disconnect between our medical education and then the evolving science in that area. This stuff we've known really about the physiology of this condition for 20, 30 plus years. It just hasn't made it into the mainstream. So a lot of my hope is to really kind of bring awareness about it. That's what my presence on social media has been about. And I appreciate you guys following along and, learning with me, sort of challenging me, making me think. It's helpful. Man, okay. Lot of questions came in. I'm going to try to get to some of these. What's the likelihood of gallbladder problems after your surgery or after any weight loss? So anytime you lose a lot of weight, there's risk of exacerbating underlying gallbladder issues. Just as an FYI, usually it's correlated with very rapid weight loss. So if you lose a lot of weight very quickly, which often happens in bariatric surgery, that people can lose 20, 30 pounds very quickly within a month or two, that you can sort of, if there had been some low-level gallbladder disease or gallstone disease, that can manifest more acutely. And so there's a theoretical risk. It's hard for me to give an exact number on that because it really varies on the person. And sometimes people aren't aware of this being an issue until it manifests. So some people are lucky and they've already been told, and so it's something they can watch out for and kind of monitor. Sometimes they can take a medication called ursodiol, which helps dissolve the gallbladder sludge and prevents it from coalescing and forming gallstones. That's sometimes helpful as like a prophylactic if you know you're going to lose a lot of weight. How to lose weight after gastric sleeve, and I also have Ehlers-Danlos. I've never taken care of a patient with Ehlers-Danlos. That's a connective tissue disorder. I actually don't know how Ehlers-Danlos impacts weight loss per se. There may be a unique mechanism there that I'm not aware of, and whether or not that makes it harder. I certainly know how it affects sort of your joints and connective tissue. I suspect that many of the things that I talk about as it relates to whether or not you'd be appropriate for medication or something else, that they would be similarly applicable to you. So I don't think that you would have any sort of unique contraindications to medicine if you are someone who struggled to lose weight after bariatric surgery. So that's where thinking about weight loss medication can be helpful if you're someone that's had surgery, had a good response, maybe has started to gain some weight back, that you could think about that as a way to either stem the tide or help you lose some more weight. Are there appetite suppressants that you recommend? Nothing dietary, nothing over the counter that's, really worth a darn, unfortunately. There's a lot of like these Mexican roots and stuff people keep sending me on TikTok that I looked up, and there's just no good data around it. Caffeine a little bit can suppress your appetite a little bit, but you build up a tolerance to caffeine, so those effects wane. Green tea, same thing. Anything with caffeine in it, it's sort of a limited effect. So if you cycle off it, maybe, but it's not going to be very potent. Otherwise, that I think prescription medication like phentermine, which was like the first appetite suppressant, would probably be your best bet if you're looking at something like that, if you feel like you have a really sort of unruly appetite that way. And exciting, I was going to do a video on this. I haven't done it yet, so it's kind of a sneak preview for you guys. There's a new, for many of you guys who are like kind of interested in surgery, maybe not so sure about medicine, surgery's kind of maybe a little a step too far. So a new drug that just got FDA approved, it's kind of like, I don't know if it's classified as a device or as a drug. It's called Plenity. It's made by Gelesis, is the pharmaceutical company. It's a pill, multiple pills that you take, and it forms a hydrogel in your stomach as it hits the stomach acids and mixes with the juices. It expands to 100 times its size. It's like getting an intragastric balloon placed, but it's natural. It's made by like fiber type derivatives. So it's like eating like 15 bowls of salad. You can take this like prior to a meal, and it works basically for the whole day, and then you basically like poop it out afterwards. Their study that they published was pretty decent in terms of the weight loss efforts. And for people that have insulin resistance, so prediabetes, diabetes, metabolic syndrome, PCOS, for those individuals, they were twice as likely to lose 10% or more. So this is something that you could take. It doesn't get absorbed into your body. It's not technically really a drug. It stays within the gut. And it basically makes you full because it expands. And once you get expansion, those nerves connected to your stomach, they sense that as you sort of having eaten, having had enough, They basically tell your brain that you don't need to eat more. So the medication's called Plenity. You can actually go online to their website and talk to one of their doctors and get it prescribed there. I think it's like $95 a month for their service. It's going to eventually, they said, in 2021 is going to roll out to kind of insurance plans across the country and be available at pharmacies, but right now it's only online through their website. So that's another option. It's not a drug. I think it's considered more of a medical device than anything, but it's not even permanent. It's just it's like eating something that's, eating a bunch of fiber in many ways, but just like kind of fiber on steroids. So that's kind of an interesting new tool that we have. Do you do virtual appointments? I can't. I'm not licensed in other states at this time. A lot of exciting things to come as it relates to maybe the extension of my ability to take care of more people, or things that I'm involved with. Working on some stuff about that I can't talk about right now, but we'll have more to come in the near term to talk about that. Gaining weight, no one knows why. My fridge habits are on point. Blood stuff is all good. Yeah, that's tough. I mean, that's really tough. I think that in those events where you've made a lot of changes and are still struggling, I think that's really the perfect time to consider whether or not medication may be helpful to assist with weight loss. That's kind of my 2 cents about that. Phentermine or topiramate together using combo for weight loss. Yeah, so phentermine and topiramate, or phentermine and topiramate alone, they're both used for weight loss. Together, they're combined under a branded drug called Qsymia. You can also prescribe the generics separately and take them. I do that often for patients because it's cheaper. So I think I did a video on that, sort of prescribing the generics can be cheaper and be a way around sort of the screwed up drug pricing system in our country. Generic topiramate's like $10-15 a month, if that. Sometimes it's like $5 to $8. Phentermine, sometimes it's covered. You don't even have any copay. Similar with topiramate, phentermine can be like max like $15-20 out of pocket. Sometimes it's less than that once again. So the combination could be anywhere from like $20-30, whereas if you buy Qsymia, it can be $100 through their website a month, or it can be like several hundred if you go to retail pharmacy. None of that makes sense. Can we acknowledge the fact that why is that pricing system the way it is? That none of it makes sense. It's crazy. Retail pharmacy is $150. From the drug manufacturers, $100. If I get the generics, which are basically the same thing, it's $20 a month. It's so screwed up. Our healthcare system just drives me insane. I'm always hungry. When do I never feel full? There's something that can help with that. Yeah, I think this is opportunities where medicine can be helpful. There are certain dietary things you can do to help improve. Some people do better on lower carb if they have some appetite issues. Some people, it's really maximizing fiber. So we really work on optimizing their fiber intake, especially if they're more of high-risk cardiac patient. That can help improve your satiety with meals. Sometimes just, really leveraging protein. So protein's super beneficial for being full and feeling satisfied with your meals. So if you can eat your protein first at meals, I usually recommend about 1 gram of protein per pound of body weight, usually ideal body weight. So there's calculators you can look at online about what's your ideal body weight and it's based on your height. So 1 gram per pound is a really good way, and is a strong foundational component of any like weight loss diet. I would say high protein. 30% of your calories coming from protein is another way of framing that. It's going to get you pretty close to 1 gram per pound. So there are a number of ways to do it. I would say high protein, high fiber is really key. Minimally processed foods is really key, which means really cutting out fast food, cutting out fruit juices are also sort of more acknowledging that they're not so great for your health. The apple juices, the cranberry, grape juices, they are not as good as eating the real thing, eating the fruit, the whole fruit, and that they actually may be uniquely harmful. So despite sort of all of these companies marketing them as helpful and getting your fiber and stuff, the data around it actually suggests otherwise, that they may actually cause fatty liver, that they actually can spike your insulin and cause weight gain. So I really recommend people cut out their fruit juice, water, sparkling waters, diet sodas, diet drinks, maximize protein and fiber. I mean, those are like core tenets of any sort of successful weight loss approach. Roux-en-Y revision. We're going a little adjacent. That's okay. Or going off on tangents. Roux-en-Y revision, shouldn't expect the same amount of weight loss you had with the initial unless the initial was done by a bad surgeon and the revision is done by a really good surgeon. But I've seen people lose an additional 10-15%, especially if they pair it with medication. I had a patient who had a revision. She lost 17% of her body weight afterwards, but we also had her on medicine after her revision. Low dose to build your tolerance. 1,000 milligrams was too much, so I did 500. Metformin, I'm assuming? Yes. Metformin should be started at the lowest dose because it can have some GI intolerance. That's a good point. Also, the extended release of metformin is better tolerated, but usually the insurance companies will make you use the short acting first before you can do the once a day. What are some alternatives to metoprolol? I feel I've gained so much weight on this medicine. Metoprolol does cause weight gain, and some people can cause 10 to 15 kilos of weight gain. That's actually not something that's well appreciated by cardiologists or primary care doctors, but that's something that I give lectures on, or the cardiovascular meds. So Coreg or carvedilol is more weight neutral. So if you need to be on a beta blocker for your heart or for your blood pressure, carvedilol or Coreg is a better alternative if you're worried about your weight. Do you know a good surgeon in Georgia? I do not. I am not familiar with the people that practice out in Georgia, unfortunately. The ASMBS website is the American Society of Metabolic and Bariatric Surgeons, I believe. ASMBS will have listing of people out there. You can also, there's a federal website you can look at. I don't know it off the top of my head. I may have to look and do a video on this for you guys who are interested in surgery. You can actually look up the surgeon's outcomes. So you can see what their complication rates are, how well their patients do, if they've had any sort of audits or anything for questionable practice. This stuff's actually, it got mandated under the Affordable Care Act and from some of the recent legislation. So that stuff's online. You can check out, your surgeons can't hide behind any data anymore. So that their mortality rates, their complication rates, all of those data are going to be online. So if you have questions about a surgeon or you don't know and want to check it out, you can search that online. I'm sure a simple Google search of like surgeon, bariatric surgeon outcome data or something will help you do that. But it's a lot of it's through the CMS. These are like CMS databases. Hey, can an endocrinologist? Yeah, any doctor can prescribe weight loss medication. Now, whether they will or not is a whole different story. Often it comes down to their comfort level with those medicines, because you guys have to understand, we have to monitor how your body responds to it, not only the side effects, but how it affects your organ function. So if you're not comfortable with, the side effect profile of a medication or the surveillance and monitoring criteria, whether or not, say, like a drug like Contrave can, in rare instances, cause inflammation of the liver, or that Topamax can cause kidney acidosis. There's like some rare some rare things that, like, if you're an experienced clinician, might not feel comfortable doing. So that's the challenging part, is sort of increasing people's comfort level with these things, one, in prescribing them, and two, in just in practice. So I mean, that's why I do a lot of these educational videos. I also give lectures in the community and at national levels about how to prescribe these best practices. I have a lecture coming up with a group of liver specialists, believe it or not. They asked me to come speak to them and talk to them, what kind of stuff can they do for their patients, because a lot of patients have fatty liver. Fatty liver gets better with weight loss. It's kind of the primary treatment for fatty liver. So a lot of endocrinologists are comfortable prescribing, particularly some of the diabetic drugs that promote weight loss, but not everyone. How do I find a doctor like you? Why I'm flattered that you think I'm worth finding. Rigby, I think I have a few videos on that. There's a website. You can go to the ABOM website after this Q&A, or if you want to back out now, you can go check it. I have a website link that I included in the comments in the description of the video. You can go there, search your state or your city for providers. If you search your state, make sure you use the abbreviation of the state, like NY for New York not don't type it out. We found out that that was not effective. Typing it. People were like, "There's no weight loss doctors in Wisconsin or California." I was like, "That's not possible. I practice in California." I was like, "That's not possible." So yeah, the search tool is not very intuitive or very robust. You have to put in the abbreviation for the state. But the ABOM website, the Obesity Medical Association, OMA, also has a search directory as well. It was one of my first few videos. If you're just wanting someone to like help guide you in terms of like how to eat, how to formulate a healthy weight loss diet, specific questions about specific approaches to dieting, whether it's like I want to do keto but I want to do it safely and not do dirty keto, which is like 99% of keto I see when they come to my office, or if I want to do paleo or whole food plant-based or whatever. You can also find a dietitian near you. Eatright.org is the largest organization of diet and collective of dietitians. They have a search directory as well for your states, so check that out as well. Hypothyroidism and weights. Yeah, we talked about that last time. It can be tough. You want to make sure your thyroid is obviously treated and that you're not hypothyroid, that you are what's considered euthyroid. But if your thyroid is treated and you're really responding appropriately, you're not still symptomatic. Some people, about 15 to 20% of the population, may also need T3. So the typical treatment for hypothyroidism is T4. It's called Synthroid or levothyroxine. About a quarter to a fifth of the population also needs a little bit of T3, which has to be prescribed separately. So that's something to be aware of. Maybe you're not having a response because you need to be on T3. I don't know your situation. But it also may be that you would benefit from being on an appropriate weight loss medication. Once again, if you've tried a number of ways to lose weight, you struggle to get to the healthy weight, then that's something you guys should all consider if you have access to it, and you can find a provider who is willing to prescribe it. Thank you for anyone who dropped a present. I don't even know what that is, but I appreciate it. It sounds very nice. Jay Kings. Medication to stop eating or make my body let go of fat. So you can't, there's no medicine that lets you let go of fat. So the way you lose weight, as played out as it is you have to be in a calorie deficit. How you achieve that is really the secret sauce. And most of it is developing a sustainable way to reduce your food intake. The challenge that a lot of people have in the current food environment is dealing with their biology in the way that our world is structured, where it's very easy to consume. People have ready access to the worst kinds of foods for them. And when you're stressed, tired, you become disinhibited, and those sort of very fundamental biological aspects take over. And so your biology doesn't take a day off, and we often do. We sort of mentally check out. It's very easy to. And so you can see a scenario in which your biology is on call 24/7, and it doesn't take much. It can be a pandemic. The average weight gain over the last year during the pandemic is 15 to 20 pounds. So the average person in the pandemic, the average U.S. adult, has gained weight during this time. So it's been really hard. And so sometimes that means if you've been struggling, and if you're someone who is, you've been struggling for a long time and you've tried to lose weight and maybe you've yo-yo dieted and haven't been successful, that I would recommend you consider a physiologic treatment like a medication, or if you're someone who is at higher risk because you have other weight-related issues like sleep apnea, reflux disease, diabetes, you have multiple of these other issues like prediabetes, hypertension, high cholesterol, then you consider surgery as a potential option. And you find someone that can talk to you who's knowledgeable about it. So yeah, I think that it depends on your scenario, but it's not easy. I'll be honest, it's not. If it were easy, there wouldn't be the number of people who struggle. So great questions, great insight, guys. I'm gonna take a few more questions and I gotta go. Let me find here. Wasn't aware of the T3. Yeah, right. The more you know. Um, Most doctors aren't either. So I didn't know about that until I specialized in weight management, and so and I'm board. I was first and foremost a board certified internal medicine physician, and then I became board certified in obesity. Yes, a lot of people do sleeve first, and then we'll do Roux-en-Y second. That's very commonly done now. It's sort of like a staged procedure. If you can get away with just doing the sleeve, then that's probably ideal. You know, no reason to take any extra medicine, do any extra surgery if you don't need it. So I wouldn't go into it with that in mind per se, but I would say a lot of times you can do sort of the staged thing. Other medications to replace Saxenda. So getting back to the medicine topic, which was I think what we started out as. Saxenda is a GLP-1, so you can either do something within the same class if there are issues either with cost. Oftentimes my patients have, like, their insurance company will pay for like 9 months and then they'll stop paying for some ungodly reason. And so something else within the same class like Trulicity or Ozempic I would probably be my preferred. If you can't get any of those, I think Qsymia is a great option. People do really well with Qsymia in my experience and really what the data shows. And then Contrave is another one. I will tell you, Contrave is a tricky one. I probably will do a video on it because a lot of people have been asking me about it. Contrave is really, in my experience, and really what I think some of the latest literature shows, very effective for people that have a very strong hedonic eating component. And that's like people that are like, you know, like nighttime snackers, because like at the end of the day, they're really sort of emotionally just done. Or if they've been like stress eaters or binge eaters for a long time, they've had a very strong sort of emotional relationship with food. That's where I find it most helpful because it works on part of the brain called the mesolimbic system, which modulates dopamine, serotonin, opioids. That's where all those different hormones act to connect sort of your emotion with your thoughts and your motivation and reward. And so it basically helps get that area of the brain to kind of work more normally. And so people don't feel as drawn and connected to food in the same way. And they actually feel like they have a healthy relationship. For people that are just like hungry or who just struggle to lose weight or who maybe just kind of their metabolism is a little junky, I don't think Contrave works very well. So like I see this like this two end. It either works really well for people and I have people do really, really well, or I have people like it just doesn't work at all. That's in my experience. That's what we see. And if you look at the literature, it's like pretty much a wash, right? Like people either respond really well or they don't. And so the average isn't that impressive with the weight loss results. But if you look at the individual responses, you're like, okay, clearly some people respond really well, other people don't. And so I think that's where we get back to this personalization and tailoring it to the right person, and ideally having a provider who's experienced in working with patients, identifying these different types. Once again, that seems to be kind of the way and the direction of this field is going, is being able to identify objectively what kind of type someone is, and then being able to provide an appropriate, tailor the treatment, sort of that precision medicine component. All right, I'm going to take one more. Anyone else? Never feeling full. So I will give you kind of my sneak preview. I typically don't like doing this, but you know, why not? We're doing it today. So people ask me, what's your favorite? I don't like doing it because it's very personal. But in my experience, if you want to look at what people typically respond the best, and oftentimes this is when I don't really know kind of where people lie. Sometimes if you do, I find helpful if you put someone on a really restrictive diet for a few weeks, their underlying biology sort of manifests, and that makes sense intuitively because like you're forcing that biology just to have to fight back, right? We talked about that's why people struggle to lose weight. If you do that, so I will put people on a pretty low diet and they're like, why are you torturing me for 2 weeks? It's not doing that intentional, but it allows me to know kind of the biology manifests, and then I'm like, okay, we need to address this component. You know, they become like rabid stress eaters, or they'll just be like, I am just so hungry all the time. I'm like, nothing seems to quench my hunger. But besides that point, if anyone were to walk in my door and say, what would be the most effective? I'm most excited about the promise of semaglutide, guys, in 2.4, just because the consistent results, the fact that it's such a safe medication. It's been shown in diabetic patients to reduce the risk of heart disease and recurrent heart events in those patients. For a lot of patients, they also have some component of heart disease. Either they've had, a lot of my patients will have existing coronary artery disease. Some of them have had heart attacks that have come to me and they're trying to lose weight and get healthier afterwards. It's safe for those patients. So it's really safe across the board. I really like semaglutide and then sort of the sister medications within that area. So all those GLP-1s, Trulicity, Saxenda, really like those drugs because of their safety, because they're all by and large pretty effective. And they also help with a lot of people that have sort of the metabolic syndrome, insulin resistance type, which often co-occurs with people that have that are struggling with their weight. Beyond that, Qsymia is probably my favorite. So, and for some people, it may be my go-to for them, because I can prescribe it generic with the individual components. Qsymia also works in a number of different pathways. It works on the motivation and reward pathway we talked about, so it can kind of help a little bit with if you have some emotional eating tendencies, but maybe that's not your biggest issue. Maybe also there's some appetite issue, and you get hungry, or just not satisfied with foods. It can also happen. It kind of works on multiple parts of the appetite system. So that's why Qsymia is also pretty good. So between those two, those are kind of like my favorite, to go to in general. So if I had to pick, you had to put me in a room and only give me one choice, that's how I kind of think through things. Obviously within that framework, you try to personalize it depending upon patients' health risks, their individual type, etc., what they can afford. So yeah, it just depends. And then if all the medications are cost prohibitive or you don't have great insurance coverage of these, which sometimes I have people come in and they're like, I've got the Super Gotti Deluxe Executive Blue Cross Blue Shield package. You can't pay more for your insurance a year, and they have no coverage for their weight loss medicine. And I'm like, I'm sorry, like that's unfortunately the way our healthcare system works. Sometimes just standard phentermine is enough, and especially if you don't need much additional support, you just need a little, like a spotter, a little something extra. So phentermine can be helpful, and it's super cheap, very safe, especially in the hands of an experienced clinician. And yeah, so I think that's about it. That's all I think I have time for today. I got to get some more work done. Thank you guys for joining. Be on the lookout. Send me some recommendations for videos and things that you all want to see. Always appreciate the feedback I get on my videos, the mentions, questions you have, and I will try to get to them when I can. You guys take care, okay? Good to see you all. Thanks for joining.